Okay, I want to welcome everybody to our very first Bioethics Grand Rounds at Washington State University's Elson S. Floyd College of Medicine. Today's topic is SARS-CoV-2 vaccine safety and allocation. We have two very prominent speakers today who have done extensive work on vaccines, vaccine safety, and pandemic response with the National Vaccine Program Office, with the CDC, with the National Academies of Science, Engineering, and Medicine, and the World Health Organization. If anyone has a question for one of our speakers, please enter your question in the chat feature of the webinar during that speaker's presentation. After that speaker's presentation, I will select a couple of questions for them to answer, and I'll try to select a question that represents several lines of inquiry and is broad in nature and a broad appeal to our audience. I should say that we are very appreciative of both of our speakers taking the time to speak with us today. I know they are both very, very busy. Our Bioethics Grand Round series is sponsored by the Certificate Program in Medical Ethics at Washington State University's Elson S. Floyd College of Medicine. The certificate is focused on clinical ethics and is offered in collaboration with Kaiser Permanente's Northern California Regional Ethics Program, whose staff bring extensive experience in hospital-based clinical ethics consultation to our certificate program. You can see here in this slide the web address to find out more information about the certificate in medical ethics at Washington State University. With that in mind, I will introduce our first speaker. Our first speaker is Daniel Solomon, who is director of the Institute for Vaccine Safety at Johns Hopkins University and is the former director of vaccine safety at the National Vaccine Program Office. During the 2009-2010 H1N1 influenza pandemic, Dan oversaw the most comprehensive vaccine safety monitoring effort in U.S. history. At this point, I'm going to turn things over to Dan, who will share his screen and begin with his presentation. Dan? And you're muted, Dan, just so that you know. You're muted.
Are people able to see my screen now?
Yes, your screen is now appearing.
Fantastic. Tom, thank you for the introduction and thank you for the opportunity to speak with everyone today. I'm putting my slides on slideshow, so bear with me 1 second. So I'm going to talk with you today about vaccine safety communication in a pandemic. A lot of my comments are going to be based on my experience with 2009 H1N1, but really try to relate it to what's going on today. So, with crisis can come opportunity. It's certainly not assured, but it's the possibility. And I think that for vaccines and public health, there's never been a greater opportunity for a COVID vaccine to have an impact. I mean, the morbidity and mortality, social economic disruptions of COVID are just incredible. And we have what look like very effective and vaccines with a very good safety profile, two already with emergency use, another one that may come up soon. And this is really the opportunity to demonstrate both the value of science and the value of public health to control an outbreak, but also the power of vaccines. And there's challenges though. The vaccine the first two vaccines at least use new technology. I mean, it had been in development for a long time. And one of the nice things about this approach is that you can really rapidly develop a vaccine for a novel pathogen. But the program, Operation Warp Speed, well, the name in and of itself frames it as something done very, very quickly. And it's based on the presumption that if we build it, they'll come. And this may not be the case. I mean, the actual stated objective of Operation Warp Speed was to get everybody who wanted a vaccine. And one could have that objective achieved and have no impact on the pandemic if people don't want the vaccine. We see wide variability in perception of disease burdens, with substantial proportions of the population thinking that, it's being overblown, it's a hoax, that there's medical facilities and providers that are getting reimbursed more for COVID diagnoses and mortality and treatment. The response from the US is such a clear and utter example of politics impacting science and response. And with that comes all the loss in credibility. We see this at a time where there's already distrust of the pharmaceutical industrial complex, and the perception that the vaccine is rushed. So you put this together, and we're not in a great place for rolling out the vaccine. The most recent data we have, which is from the first 2 weeks in December, shows that about 50% of the population wants the vaccine as soon as they can get it. About 10% have made up their mind not to get it, and about 40% are in this wait and learn space. And it's really important that we inform them and that they get vaccinated if we want to see the potential of vaccines realized. Now, maybe things have gotten better in the last 6 weeks, but we still have a substantial proportion that are uncertain. And what I really want to focus on here from a safety perspective is the potential for real or more likely coincidental adverse events derailing the program. And what does vaccine safety science need? Well, it needs rigor. And the approval process ensures that the benefits outweigh the risks for the populations and outcomes studied. Our clinical trials in this case were pretty large, and I think there's very compelling data to indicate this. But we need observational studies after the vaccine is approved to look for events that are uncommon, or populations that were either excluded altogether or as subpopulations were inadequately powered, and also for delayed onset adverse events. And an infrastructure to do these large population-based real-world data is really, really important. And in particular, large healthcare databases, both for rigor, but also for timeliness, because here size really does matter. And here's a table I'm sharing. I adapted this from a paper Susan Ellenberg wrote a long time ago, arguing for large, simple trials. But what I want to highlight to you is the rate, the background rate first. So this would be for something that happens 1 in 1,000 people. And that would be the background rate in the general population. And if in a clinical trial, you wanted to capture a doubling of that rate. So something bad that happens to 1 in 1,000 people now happened to 2 in 1,000 people because of the vaccine. And that would require a sample size of 50,000 to identify that difference. Now we got one vaccine in this country, and you missed that, would result in 328,000 of those adverse events, whatever they might be. So the point here is to really emphasize the size that are needed for vaccine safety clinical trial purposes, and the potential, because everyone or almost everyone is getting vaccinated, how many people could be impacted. And if it were a 2-dose regime, that number would be twice as large. We also have the problem of the fallacy that because one thing happens after this, that there's a causal relationship. And this is a huge challenge for vaccines and a huge challenge in mass vaccination programs. This was a paper we published in The Lancet right before H1N1, where we went through different adverse health outcomes, Guillain-Barré syndrome, spontaneous abortion, and then using different methods in different populations, how many would occur within 1 day or a week after vaccination. And the point is that bad things happen to people every day. So what is needed in monitoring for safety? Well, you have to adverse events that are following immunization and figure out if they're real. There's a potential for a real safety problem. Guillain-Barré in 1976 is a great example where the pandemic didn't occur, but the vaccine caused Guillain-Barré in about 1 in 100,000 people. But then you also have these spurious associations, right? Because bad things happen to people every day, and they will happen after vaccination. I mean, imagine if you vaccinate everyone in the nursing homes. Well, how many bad outcomes happen in nursing homes every day? So what you need is the ability to distinguish between the two, between real adverse reactions and those that are spurious, just coincidental adverse events. And you need to do it with rigor because you need to be confident in your assessment. You need to do it quickly because these issues out there can just undermine a vaccine program. And it has to be done with credibility because people have to believe your findings. So I'll give a couple examples of what has worked and what hasn't worked. The Qatar incident was shortly after the launch of the polio vaccine, and there were reports of paralysis following vaccination. And CDC's EIS program had just been established to have rapid field epidemiologists in case there's an outbreak. And they investigated these reports of paralysis and found that primarily from one manufacturer, Qatar from Berkeley Laboratories, but not only. The vaccine was not fully inactivated and it had actually caused wild disease. The vaccine program was halted. I think it was a matter of days, maybe a week. But because of this rapid investigation, because it was fast, it was robust, it was rigorous, and objective, people believed it. The program quickly resumed, and we're now on the verge of polio eradication. One can reasonably ask if this had not been handled how it was, what impact that might have had on the polio vaccine program. And I'll use as another example the 2009 H1N1 safety monitoring. At the time, there was a crisis in confidence around vaccines. I mean, that sounds like maybe a bit odd for people to say 10 years ago. But at the time, there were papers being published describing this crisis in confidence. And this was the last time we had tried to vaccinate everyone quickly was the 76 swine flu fiasco. And with comprehensive safety monitoring following these approaches, um, you know, we didn't have this crisis. One can never prove causality from any case study. I'm giving a few, but we had the systems in place to ensure that the safety monitoring was done. Well, what hasn't worked? And there's a few examples here, and I'll go through a couple of them. But let's take the NMR example. Is otherwise healthy. And the first hypothesis that it was the Nmr vaccine, and then that hypothesis shifted to it was the Nmr vaccines, and then the hypothesis shifted to that it was simultaneous vaccinations and how many at one time. Well, as of last year, we had 16 well-conducted studies looking at these three outcomes. They were done by different investigators using different methods and different populations, and all 16 of them were negative. So, people can ask, well, does this science even matter, right? Because, here's all the science that the vaccines and their components don't cause autism, yet a quarter of people still report that. But if you look at these same studies on a timeline, and first you see in February of 1998, when Andrew Wakefield raised the NMR issue, it took 18 months to get the first study published. And that was data from the UK. We didn't have US data for much later. So look at the time between when this science became science, and meanwhile, you had a very charismatic, well-credentialed British physician traveling the world and going on 60 Minutes supporting this claim. So the science was there, but it was done late. Likewise with thimerosal in vaccines. This became a public issue in July of 99. But look when the science was done. It was done 4 years later, 3 years later, 5 years later. So it was done, but it was done late. The multiple vaccines, it's happened, how long it took for them. And I think this is formative. So good science takes time. Whereas anecdote and sensationalism and bad science travel very quickly. And fundamentally, you want science to inform what people do, people believe, but it's hard to change people's mind. You have all sorts of heuristics from cognitive dissonance to affirmation bias. And really what we need to do is have the science to inform what people believe. And when a safety issue arises, to respond to it rapidly, rigorously, in an incredible way. So I'm going to stop there, Tom, and I'll turn it over to you for any questions or discussions.
Thank you, Dan. Yes, we have a couple of questions. I'm going to try to summarize. The first is a question concerning pauses in vaccine trials. We've seen a couple of pauses in vaccine trials, and we wondered if you could speak to whether these are common and how we should take these pauses and whether they should be reasons to be concerned about the safety of current vaccines.
Yeah, no, I think it's a great example of a missed opportunity. And Saad can discuss this as well. He knows clinical trials very well, but a clinical trial has a data safety and monitoring committee, and they have the capacity to unblind the data. And their goal is to make sure that the benefits still outweigh the risks. So they have the power to stop a trial. And if they look at the benefit and it's so overwhelming that it would no longer be ethical to keep people in a control group, they could stop it for that reason, or they can stop it because there's a potential safety issue. And it's not uncommon for them to look at something and say, okay, let's wait a minute, let's pause it, let's look at these data and make sure we're good to go. So their job is to protect the study participants, and that's exactly what they did. And I frame this as a missed opportunity because I think if this could have been explained to people, what it really demonstrates is the system works. There are objective, knowledgeable people looking at the science, and they're making sure it's being done properly.
A second question that I have here is if you could speak to the application of the precautionary principle to the novel DNA or the novel mRNA vaccines. Was there a genomic investigation of the progeny of vaccine recipients, et cetera? And could you speak in general about the precautionary principle and its application to these vaccines?
Yeah, well, that's a tough one. So my understanding of the precautionary principle, which is not my expertise, but that in European regulators, the approach follows the precautionary principle, which says one needs to show something is safe and not presume it. So, for example, for food products or home items, it's the presumption of proving something is safe first. So that's my understanding of the precautionary principle. It's not my expertise, and perhaps the person that's it better than I. I think applying that understanding to vaccine development, I think that as I understand the question, it's was proper care taken? And I think that with vaccines, there's tremendous care taken to make sure that any novel technologies are in fact safe. I'm not a vaccine developer, so I can't be that can explain to you, what biological testing was done on this technology, what animal studies were done, what laboratory studies were done. Um, so that's my best answer to your question, which is you're outside of my expertise.
Great. Well, I promised you one or two questions, Dan, so I will allow you to get off of the stage at this point and introduce our next speaker. Our next speaker is Saad Omer. Saad is the director of the Institute for Global Health at Yale University College of Medicine and is the Susan Dwight Bliss Professor of Epidemiology of Microbial Diseases at the Yale School of Public Health. Saad serves on the National Academies for Science, Engineering, and Medicine's Committee for Equitable Allocation of Vaccine for Novel Coronavirus. He is a member of the World Health Organization's Global Advisory Committee on Vaccine Safety, and he is a member of the World Health Organization's Strategic Advisory Group of Experts on COVID-19 vaccines in particular. With that, I will turn things over to Saad, who can share his screen and take over from this point with his presentation. Saad?
I was on mute. Yeah, I'm assuming you can hear me properly now without any interruption.
Yes, we can, Saad.
Yeah, so it's my pleasure to be here and to speak to you. And it's always good to interact and work with Tom. And Tom, if I don't know if you remember our first the full paper together, or so our first detailed interaction was around pandemics ethics. The paper came out in 2008. I think we started the collaboration in 2006. It was on duty to treat in a pandemic. So that is to say that a lot of things, a lot of folks have been working on pandemic-related issues even before the pandemic, in the so-called or depressively labeled inter-pandemic period. That meaning that you're always waiting for the next pandemic, and so it's always a pleasure to interact with Tom and others. I'll be talking about a few prioritization frameworks in my talk. The first one is where I was directly involved with, actually I'm involved with 2 out of 3 of the frameworks that I'm going to talk about. I have the privilege of being a member of the National Academies of Science, Engineering, and Medicine framework for equitable allocation for the COVID-19 vaccine. And this committee was established this framework was developed by a committee that was charged by the NIH and CDC directors to come up with an overall framework, then was supposed to be used by the CDC and the states to issue their overall allocation frameworks. So there are several elements of those frameworks. First of all, we settled on a goal for reducing morbidity and mortality and then negative societal impact due to transmissions of SARS-CoV. So that was the overall goal. And we developed, in terms of various groups, a risk-based criteria. So risk of acquiring infection, risk of severe morbidity and mortality, risk of negative societal impact, and then risk of transmitting infections to others. And quickly settled on 4 phases in that framework. And I'm going to talk about all of these. One of the things that became very clear early on, so there was some initial abstract discussion. So this was done well before the current debates and discussions. So this was over the summer, or late summer at least. And the idea was to have, one trade-off was whether to interrupt, whether to have a goal, a public health goal of interrupting transmission or directly reducing morbidity and mortality. And it became very clear that even if you look at mortality, compared to age groups such as 18 to 29-year-olds, those who are in older age groups, even in 65 to 74 years, had substantially higher, 90 times higher rate of mortality. So it's not 90%, 90 times higher. So these contrasts were pretty substantial. And this kind of stuff became part of our considerations. So therefore, the public health strategy that underpins the allocation framework, and that surfaces in several state frameworks as well now, and increasingly so, was to directly address morbidity and mortality, and do a mortality first approach. So start with mortality, and then go and then increase your coverage to a level where you can interrupt transmission. The first reason was that death is irreversible. You can have a second semester or an additional summer semester of schooling, technically speaking. Obviously, there are inequities that are likely to stay with us after this pandemic. You can provide us an economic stimulus, but once someone is dead, you can't bring them back to life. The other thing is there's social consensus on preventing severe morbidity and mortality, and we need a critical mass to vaccinate to get to the interruption of transmission. So therefore, the first doses should probably go to directly protecting individuals. But the trials, again, are not designed to assess impact on transmission. and then limited transmission data in terms of risk groups. So even at that point, that was the reason, one of the reasons we went for mortality first strategy. The ethical principles were maximizing benefit, equal concern for everyone, along with mitigation of health inequities. So these are the principles we explicated. But on top of that, we thought that it was important to have procedural principles, including fairness, transparency, and focus on evidence. And we said that, look, the evidence is going to change as long as you are making decisions um, based on evidence, based on the best available evidence, you're on good side of ethics. So therefore, that framework, which came up with the phase one, and the terminology phase 1A and B came from that original framework, it had a jumpstart phase, but the idea was that the phase one should be administered together. And so the groups there that were included were high-risk healthcare workers. They did not include all healthcare workers, and that was intentional. And first responders, it was a pretty small size of people at 2 to 3 million. Then people of all ages with significantly higher risk associated with comorbidities. So not all comorbidities, not all 6 comorbidities that CDC defines. And then older adults living in congregate or overcrowded settings. So that's what was done. And it was said that within that, ideally, you should have a full first phase, but you can have an initial jumpstart phase within that to get things going with healthcare workers, but only in high-risk healthcare workers. Then the second phase included teachers, because the irreversibility of the developmental outcomes, especially for elementary school teachers and their function, was very critical. You cannot sort of reverse that. Then critical workers in high-risk settings, and we defined it based on an index that a colleague from Hopkins have come up with that looks at telecommutability fairly objectively of those professions. Then people with moderately high risk based on comorbidities, people in homeless shelters, people in incarcerated, in detention centers, etc., who are otherwise incarcerated. And then all older adults not included in phase one. We intentionally did not have a cutoff because we thought that at that time the data were not solid enough to have a specific cutoff, but we tentatively took 65 and above as the cutoff. Then moved to phase three and have young adults and children and workers in other industries which are not previously included, but are still critical for functioning of the society. And phase four would be as I would say, the Oprah Winfrey phase of vaccination, meaning you get a vaccine, everybody gets a vaccine. And then we addressed equity by not prioritizing sort of race or any other characteristics in each of the groups. The recommendation was, and the reason for not doing that so directly was, first of all, there would be an increased suspicion in people of color that why are you just exclusively focusing on us? The second was that there are other social determinants of health than race. And the third thing was that it may face legal challenges. And so therefore, the focus was to have an equity centered approach which focuses on the location, which says that you ensure access, you ensure equity by ensuring access in populations where these the impact is disproportionate. And so the social vulnerability scale, we said that CDC's social vulnerabilities index should be used to ensure access in socially vulnerable areas. And so the scale and the index had 15 census tract variables, and some of them are directly relevant to these to COVID-19 risk factors, including race, income, transportation, availability, crowding, or proportion of older individuals. And the other thing is it can be calculated fairly quickly at the census tract level. Switching to another aspect of domestic ethics, some of us came out with a framework of whether or not to have mandates in these kinds of situations. And we took a nuanced perspective on this. We didn't think that mandates should be the first line of action. But we did think that governments and sometimes private entities could explore this option and would be tempted to explore this option. And when we laid out 6 criteria, so this came out in the New England Journal in July, and the idea was to have to say that you can't and you shouldn't have a mandate if it is if the disease, you should only have a mandate if the disease is inadequately contained. ACIP has recommended, so just licensure is not sufficient. The vaccine, there's adequate supply, there's transparent communication about risks and benefits, there's an infrastructure present to deliver the vaccine, and then there's inadequate voluntary response. And that hasn't been met for most of the country at this point, and may meet, some population may meet those criteria. But once you do that, once you get to that, we propose that there was the penalties should not be draconian, and it shouldn't be that you're picking up people and sort of jabbing them with vaccine. There should be a more balance of convenience approach, and I'd be happy to discuss what kind of enforcement mechanism we proposed. The CDC ACIP initially said that they're not going to issue an overall allocation until they have vaccine recommendations, until the vaccine data come out, but then they sort of reversed their decision in December. And unfortunately, between the NASEMS framework and the CDC framework coming out, there was a huge gap. And within that, a lot of states came up with their own thing, and that led to a lot of confusion at the state level. Nevertheless, this ACIP had phase 1A, so it substantially overlapped, as was expected with the NASEM initial overall framework. One distinction was that it contained all healthcare personnel. So the size of the first phase was much larger than the initial NASEM proposal, and then also contained long-term care facility residents. In the second phase, which is, again, comes after a lot more people than the NASEM framework, the National Academies framework, had people older than 75 and non-healthcare frontline essential workers, and then persons aged 65 to 74 came in 1C. So there was this issue because of this group, this expanded group of healthcare workers and non-healthcare frontline essential workers. This group ballooned substantially and did not take into account a few things. First of all, the reason for healthcare frontline essential workers being included in this group was that ostensibly that there are more people of color in essential workers, and therefore addressing inequities that way. But there's a problem. There's a trade-off. But the fact is that then if there are approximately 75, 77% deaths, wide deaths covered, if you have a cutoff at 75 or older, but if you go down to 65, you're covering, and only 44% approximately Black deaths due to COVID-19 covered, if the cutoff is 75 years, because unfortunately people of color in this country die early, and especially our more younger age groups are relatively more impacted by COVID-19. But if you brought down the age cutoff to 65 to 74, meaning you didn't have to account for this group, you were more directly addressing some of these inequities in mortality. So there was some issues and critiques of the ACIP recommendation around there, but also it did not directly address access, any objective criteria for ensuring access at the local level. So switching gears a little bit, I have the privilege of being involved with a similar process at the WHO level. And the working group had issued a values framework, so articulated the values we are going to use and the countries should use before any specific recommendations came out, but also issued a prioritization framework before any vaccine-specific data were available, that these are the groups that should be prioritized, knowing what we know and expect about the vaccines, and then said that if things change based on the vaccine characteristics, you can tweak these overall prioritization. And then the group has been issuing vaccine-specific, the SAGE group has been issuing the vaccine-specific recommendations. There are separate COVAX allocation framework that I'm not going to go into the details of. The core framework was very similar. It didn't differentiate between procedural sort of principles versus core principles, but essentially human well-being, global equity, reciprocity was engaged. And we said that even in situations where healthcare workers are not right now dying at higher risk, although we have data from outside the US where the risk is even much higher, based on the reciprocity that they took a substantial risk, and in addition to the fact that you need healthcare workers vaccinated to have a sustained system of healthcare, you need to vaccinate them. And so, and then equal respect, national equity. So at the subnational level, we prioritize that, and then legitimacy, and say that the process should be transparent, legitimate. It shouldn't be that the junta gets vaccinated and people don't. And so we laid out some of these guardrails. And so the three epidemiologic scenarios that we have include community transmission. So the other thing we did was that countries were different based on their epidemiologic situation. And so different prioritization applies to them, and different rationale. The community transmission scenario is similar to the US, where there's ongoing community transmission. Then there is sporadic cases that, there are a few clustered cases, but not ongoing transmission. And then no cases, like New Zealand, like China, like, now Australia, that there are minimal cases, but there's always risk of importation. And the strategy for community transmission is, again, similar to the NASEM one, initial focus on the direct reduction of morbidity and mortality, and then maintenance, then expand to maintain critical essential services and reciprocity, and then further expand to reduce transmission. Don't focus on transmission earlier on. Similar strategy for when there are clusters of cases. And the way it was applied was that you were not making recommendations for the whole country, but you're focusing on targeted groups. But mortality first, critical services first, and then expand to interrupt transmission. When there are no cases, the idea was to prevent the virus from taking hold through importation, etc. And then you expand to preserve the control of transmission, and then ease up on the most cumbersome measures. So that is the situation where you have a New Zealand or Australia kind of a situation. And we assume that the recommendations didn't go beyond 50% coverage, because we thought that at this point that should be the focus. And realistically speaking, most of the world will not get to beyond 50% coverage anytime soon. There will be a few exceptions. Hopefully that would include the US. But then there were stages that were covered 1 to 10% coverage. Stage 1 covered 1 to 10% supply. Stage 2 covered 11 to 20% supply. Stage 3 covered 21 to 50% supply. And the idea was that within each, the groups were staged sequentially, and groups within stages were not ranked orders except for the first stage, 1 and B. And then in some countries, the vaccine, further prioritization may be required. So we acknowledged. I'm just giving you an example of the community transmission scenario. I'm not going to go into the other two scenarios, but essentially, this is the strategy as I articulated. The first stage is, in this case, it's much simpler than the US one, which is to start with healthcare workers, again, very targeted at high to very high risk, and then go very quickly to older adults defined by country-specific age cutoffs. The other groups are similar, but you expand more slowly, similar to the NASEM framework. Older adults not covered in stage 1, individuals with comorbidity with significantly higher risk. So not just everyone with diabetes, etc. One way of looking at it is multiple comorbidity. Other one is to single out comorbidities like chronic kidney disease, etc., that put you at a pretty substantially high risk. And then this says targeting groups that are significantly high risk of severe disease and death, health workers engaged in immunization delivery, and then high priority teachers and school staff. And what with that we meant especially elementary school teachers and staff, because the idea is that period of development, when that is lost, that is harder to make up compared to older kids and other individuals. And then there were a few other groups in the stage 3. So I'll pause here and would be happy to take questions.
Okay, Saad, a couple of questions that we've got so far is, I'll give you one and then we can take more if you have more presentation. One is, Given that people in high-risk populations are having trouble obtaining appointments and doses for vaccination, do you think we are moving too quickly through the phases, given our limited supply of vaccine?
I think, well, here's the thing. Uh, I, I think there was always going to be an overlap. So I'm okay. And I think it's reasonable to go very quickly to 65 and older for equity reasons, for simplicity reasons. We should do two things. We should make sure that we do not further complicate that. If you are going to go to 65 or older, stick to that. Don't add more groups beyond very targeted group like teachers, etc., and frontline workers. So that would be my suggestion. Get that age group covered, and you have reduced mortality significantly, including one group that I am very concerned about, and I think that's what they're alluding to, which is the long-term care facilities. If you are moving through the groups and you're going down to lower and lower risk groups and you're ignoring the group which is at really high risk, then you have a problem. And I think we need to have concerted efforts to make sure that our long-term care facilities are covered adequately and their staff are covered very adequately, so that we have a um, a situation where we have reduced mortality to such an extent that even if there is transmission going on, we are saving lives in substantial numbers.
Another question I have here is, do you think that lack of knowledge about the novel coronavirus is increasing vaccine hesitancy? That is, the willingness of individuals to accept vaccination.
It is. Not just, so usually, Dan and I collaborate on vaccine acceptance work as well. Usually we don't have an information deficit scenario. We have a persuasion scenario. But when there is a novel vaccine, there's a true information deficit, and that decreases confidence in the vaccine, not just by folks, by common people, by the general public, but also by providers in terms of taking and recommending the vaccine. So therefore, we need a national vaccine education effort. We don't just need vaccine persuasion effort, we need a true education effort where you are dealing with actual transmission of information and so on and so forth. So I think I agree that it is fueling some of that concern.
How would you weigh the risks and benefits of giving only one dose of a two-dose vaccine, as some countries have chosen to do?
Yeah, at this point, I think the data suggests that we should stick to a two-dose schedule. However, the one dose results are intriguing. And the reason why they suggest that is we are facing a new variant and we are dealing with high-risk groups at this point. So specifically in high-risk groups, and we know that conventionally speaking, the efficacy is lower in older populations, for example. So that's one of the highest risk groups. But we are getting good efficacy and consistent efficacy after two doses. So let's not mess with that part. But for other populations, et cetera, or for, with one dose, the data are intriguing, but not definitive. So that creates the classic equipoise to do trials, not the full 30,000 people trial, but trials with immunogenicity endpoints. And so therefore, I think this is the time to do those trials and get some serious data out on one versus two dose schedules.
I have one more question here for you, Saad. It appears that richer countries are buying up a large proportion of the vaccine supply.
Yeah.
Given increasing globalization, do you think this is likely to prolong the COVID pandemic?
We actually did a model on that, and we showed that it is in rich countries' self-interest that once they approach herd immunity to give, to rather than going beyond that, to start giving vaccines to others, even if they have the supplies. But even short of that, there was no excuse in the US sitting out when COVAX facility was being developed and it was starved of resources. And now the US has said that we're gonna join COVAX. So the COVAX facility is the group of major agencies like Global Alliance for Vaccine and Immunization, WHO and Coalition for Epidemic Preparedness Innovations coming together and creating this really solid group, entity where vaccines that are promising will be used and deployed to low-income countries uh, at at reduced cost, etc., and make it accessible for low-income countries as well as high-income countries. So high-income countries pay a little bit more, and then low-income countries get access as well, and so on and so forth. The US was sitting out and was not supporting that, was not providing funding for those kinds of things. And that could have been, could have reduced inequity substantially by adding certainty to the process, by COVAX going in and blocking some of the vaccine and doing those deals early before other individual countries could come in. So that the world will pay for it, and it is in our self-interest to do so. I'm still understanding of the U.S. kind of scenario that right now the administration announced that we're going to buy up to 500 million doses, so which is to vaccinate generally the adult population. What Canada has done is that they have bought up supplies that is 3 times the population. I think is crosses into inappropriate. So there is a fine balance, but I do think it's in our self-interest to make sure that the whole world gets vaccinated.
And I have one final question for you, Saad. I have a question here that asks, how is efficacy of a vaccine defined, and how is it tested?
That's a really good question. So efficacy is the reduction in incidence due to the vaccine. And so the way you calculate is that you vaccinate a bunch of people, and if there is disease going around, some of them are going to get vaccinated. Some of them are going to get infected, and some of them are not going to get infected. You look at the infection rates in the vaccinated people and infection rates in the non-vaccinated people, so control arm versus the vaccine arm, and you look at the reduction in incidence in the vaccine arm control compared to the control arm, so vaccine group versus the control group, and that's the reduction. That is essentially your efficacy. So that's the efficacy you're talking about. And it can vary based on the endpoint you're using. And the ones that were used for this vaccine were endpoints associated with reduction in lab-confirmed symptomatic disease. The other secondary endpoints were severe disease, etc. In fact, I think it was a concrete, solid endpoint to choose, and that's where 95% efficacy was shown for the mRNA vaccines.
Okay, well, thank you, Saad, for your willingness to provide us this information and share with us your knowledge and expertise in this area. We're very grateful for that. I want to thank everyone for attending our very first Bioethics Grand Rounds. I want to remind everyone of the certificate in medical ethics, which has sponsored this Grand Rounds, and to let everyone know that the recorded version of this Grand Rounds will be made available eventually, and that our next Grand Rounds is already scheduled. That Grand Rounds will take place on April 28th of 2021, again at noon Pacific time. For those of you who are on the East Coast like Saad, you're welcome to attend. It would be at 3 o'clock Eastern time, but at noon Pacific time, again on April 28th, 2021. And the topic of that Bioethics Grand Rounds will be health professional rights and obligations during pandemics. And we have one confirmed speaker so far, the former director of the American Medical Association Institute on Ethics, Matt Winia, and we will have a second speaker as well. So please join us in April, and we will look forward to seeing you there. Again, thank you very much, Saad, and thank you everyone for attending this very first Bioethics Grand Rounds at Washington State University's Elson S. Floyd College of Medicine.
Thanks.
Thank you.
Bye.